Thanks everyone for coming this morning. I have the pleasure to introduce Dr. Louis Tony from Seattle Children's. He's been playing an integral part in us reviving and regenerating our pediatric newborn echo program here. He currently works at Seattle Children's and covers basically from Tri-Cities up to Wenatchee, down to Yakima, over to Montana, up to Alaska. He covers a lot of ground, and we're very fortunate to have him. His special interest is in both fetal and newborn echoes and pediatric echoes. So thanks, Dr. Tony, for coming.
Thank you to Dr. Moran and Carol for setting this up and for inviting me to speak here. So I'd like to cover several broad topics and provide a transition between our antenatal screening and postnatal screening, and in the process explain the importance and limitations of each approach and how using a combination of those approaches can really provide the best possible outcomes and the best possible care for pediatric patients. So just as kind of an outline for our discussion today, so we'll talk very generally about congenital heart disease and the specific lesions that we see. So we'll talk about the acyanotic lesions, the cyanotic, and some of the more complex lesions, and specifically about critical congenital heart disease, what that means, because that's really the most important part of the whole screening process. And I'll explain why that is. We'll talk about antenatal screening in detail. Also the purposes of fetal echo, what are the indications for fetal echo, and what are some of the limitations. Likewise with the postnatal screen for congenital heart disease, I'll go over some examples of critical congenital heart disease versus the non-critical lesions that we see. The universal screen that has been established by the American Academy of Pediatrics, the American Heart Association, and the timing of evaluation. Can everyone hear me okay? So congenital heart disease is the most common congenital disorder in the newborn population. So we break it down into acyanotic lesions, where the oxygen saturations are going to be normal, cyanotic lesions, and then the critical congenital heart disease. So some examples of acyanotic defects are ASDs, VSDs, patent ductus arteriosus. We could have valvulopathies, so pulmonary stenosis, aortic stenosis, so any pathology of one of the four valves. Arteriopathies, so we could have coarctation of the aorta, we can have an interrupted aortic arch. Cardiomyopathy can be seen in the newborn period, so some people actually consider that in some cases to be congenital if there is an intrinsic abnormality in the myocardium. And then some miscellaneous things which we won't focus on today, but coronary artery malformation, where one of the coronaries originates from the wrong side of the aorta. So some quick examples, and I'll just go through basic anatomy of the heart, just to make sure we're covering all our bases. So this is the right side of the heart, the left side. So the top chambers are the atria that collect the blood. Bottom chambers are pumping chambers, the ventricles. So here we have the right atrium that receives our systemic venous return from the from the superior vena cava and inferior vena cava. Goes through the tricuspid valve into the right ventricle, out from the pulmonary valve to the lungs. And then that pulmonary venous return comes back to the left atrium, across the mitral valve into the left ventricle, and out the aortic valve and aorta out to the body. So an ASD is going to be a hole between the top chambers of the heart, or the atrial septum. Whereas a VSD, or ventricular septal defect, is going to be a hole between the bottom chambers of the heart. And the nice thing about these images is that they're color-coded, so they give you a sense of what the oxygen saturations are expected to be. So notice that in both those cases, the saturation of blood that's going out to the baby's body is still red, so they're not going to be cyanotic. So with ASDs, VSDs, with pulmonary valve stenosis and aortic valve stenosis, we have basically a very dysplastic or thickened or just very small, either pulmonary valve or aortic valve. But that's not going to result in any shifting of blood into the opposite side of the heart. So we don't have a scenario where the deoxygenated blood is contaminating the oxygenated blood. So that's why they are acyanotic. And then coarctation of the aorta is typically a discrete narrowing of the aorta, typically at the site where the patent ductus arteriosus and embryologic life inserts into the aortic arch. And again, this will not cause cyanosis after birth. Some of the cyanotic defects or just complex congenital heart defects that don't necessarily cause cyanosis, but are complex are listed here. So examples are tetralogy of below, transposition of the great arteries, truncus arteriosis, total anomalous pulmonary venous return, tricuspid atresia, pulmonary atresia, hypoplastic left heart syndrome, complete atrioventricular septal defect, and F-Stage anomaly. And I'll go through some examples. So tetralogy of below. So essentially with tetralogy, so tetra means four. And so there are typically four components of this pathology. So one is a large ventricular septal defect. And there are debates as to how this forms embryologically. I won't get into the arguments and counter-arguments, but essentially some people think that the stenosis, the right ventricular outflow tract obstruction here, will then cause the ventricular septum to deviate in a way that will then leave a gap here, that will then cause the ventricular septal defect. And it causes deviation enough to make the aorta now overriding the ventricular septum. So now the aorta is now going to receive some of that deoxygenated blood. So in addition to having a narrow outflow tract, this aorta is sitting directly on top of the right ventricle, and so that's how these fetus typically become cyanotic. Transposition of the great arteries. So in this scenario, the outflow tracts are essentially reversed. So you have all, and this is completely ineffectual circulation, where all the blue blood from the systemic venous return is going right back out to the systemic circulation. So not a very good situation for the baby. It can be very life-threatening if it's not addressed early on. And then all the red blood that's coming back from the lungs is going right back out to the lungs. Then truncus arteriosis. So this refers, and this has embryologic derivatives where embryologically the heart starts out as one linear tube and undergoes all these twists and turns and segmentations to form a four-chambered heart. And part of that process is for the outflow tract, or what we call the truncus arteriosus, to split and then rotate and then descend in a way for the pulmonary artery to connect to the right ventricle and the aorta to connect to the left ventricle. But in this scenario, something happened where that process never happened. So you have one common trunk that's then overriding both ventricles, so they become cyanotic. And total anomalous pulmonary venous return. That refers to the fact that all the pulmonary veins that are carrying that very rich, oxygen-rich blood is coming right back to the right side of the heart and not going out to the systemic circulation. Tricuspid valve atresia. So there are various forms of tricuspid valve atresia, but essentially there's no egress of blood flow from the right atrium into the right ventricle. So all this deoxygenated blood is going to cross over through some form of atrial communication into the left side of the heart. And so that now you're taking deoxygenated blood that's contaminating your pulmonary venous return, and you're going to become cyanotic. And the various forms are actually dependent upon whether or not you have a ventricular septal defect and how big that VSD is. We won't go into those details. That's beyond the scope of our discussion today. I think one of the most important takeaways in this presentation is the concept of critical congenital heart disease, because that's what we're really targeting with the screening. So what defines congenital heart disease as critical? So it's any lesion that requires some intervention, whether surgical or catheter-based, within the first month of life. So typically, the actual strict definition is 28 days, but essentially within the first month of life. The incidence of congenital heart disease itself is estimated to be about 1%. So about 1 in 100 babies will be born with some form of congenital heart disease. Critical congenital heart disease, that incidence is about 25% of that 1%. So a relatively small number, yet it can potentially be catastrophic if it's missed. So this is one of the leading causes of morbidity and mortality. Delaying treatments can cause significant morbidity or mortality in these patients. These are considered to be ductal-dependent lesions, which means that the baby requires that ductus arteriosus to remain open in order to survive. So the baby might need that ductus for systemic blood flow, so providing blood flow out to his or her body, or pulmonary blood flow. And these are examples of a ductal-dependent lesion to provide systemic blood flow. So if you have aortic valve effusion, or the aortic valve never formed, or severe aortic stenosis, or a hypoplastic left heart, or a critical coarctation, these are all left heart obstructions, so you're not getting blood out of the systemic circulation. In those cases, the baby needs the PDA to provide some sort of blood flow to the systemic circulation. If you think about the analogous component to that on the right side of the heart, those are the lesions that are ductal dependent to provide pulmonary blood flow. So if you have an atretic pulmonary tricuspid valve, or pulmonary valve, or severe pulmonary stenosis, you're not able sweep through the baby's heart, it's a little more challenging in fetal life because they can be in any three-dimensional space. These are some more focused examples of the same thing, illustrating the sweeps. And so here is a classic 4-chamber. But as you take your transducer and gradually sweep in an anterior direction, now you're starting to expose one of the outflow tracts. And then you're getting one of the other outflow tracts, and this is what we call the 3-vessel trachea view. And the 3 vessels are going to be your superior vena cava, your aorta, and your pulmonary artery. And then here's a view of the arches, the systemic venous return, the aortic arch, and the ductal arch. And just some more examples. So now we'll go through some actual specific pathology. So I just turned that original picture around because it matches some of the additional pictures I'll show. So here's what looks like a pretty normal 4-chamber heart. So if you go back to this example, we're only looking at one plane, so we are not looking at the outflow tracts at all. So we don't know anything about what those outflow tracts look like. So if, it's a little challenging for me to do this, but if you basically hold your hand over this, you can potentially see what looks like a normal 4-chamber view, but unless you sweep and look at the outflow tracts, you can miss transposition of the great artery. So now you can potentially miss a ductal dependent lesion. So here's obviously a very abnormal pathology where our outflow tracts are parallel, and the RV is now sending blood to the aorta, whereas the LV is taking all its highly oxygenated blood and sending it back to the pulmonary artery. And as you continue to sweep up, we can see some other characteristics that clue us to transpose great vessels. So here on the left-hand side, I have the normal orientation, versus on the right-hand side, we have transposition. So transposition, the great vessels are going to be side by side, so they're going to be parallel. Whereas with a normal heart, the great vessels should crisscross. So as you see here, we're looking at the aorta versus the pulmonary artery. As you sweep, what you'll see is that they will crisscross each other, and that's why we see the branches of the pulmonary artery here. But they do crisscross, so you should never really see them in parallel or the same plane. So here's an example of what looks like a very normal 4-chamber heart. So the right atrium connects to the right ventricle, left atrium connects to the left ventricle. So this patient actually ended up having truncal-soteriosis. So if you don't scan more anteriorly to get to the outflow tract, you're going to miss a very significant ductal-dependent lesion. So in this scenario, what we're looking at here, this specific plane is more posterior, meaning it's looking at closer to the back of the heart. But as we come more anterior towards the front of the heart, you will unveil a pretty large ventricular septal defect and one common outflow tract that consists of the aorta and with a pulmonary artery arising from that aorta. So this picture kind of looks similar in some respects to the one that we see here on the right-hand side. So this patient actually did not have truncal-soteriosis, but had tetralogy of below. So the difference is with truncus, the pulmonary artery is coming off the aorta. So this is definitely a ductal dependent lesion. Whereas with tetralogy of below, if you keep angling more anteriorly, it'll turn out that the pulmonary artery and the aorta are separate vessels. And if you were to measure these branches and the main pulmonary artery, they may be small, but they may be sufficient, and the baby may not be significantly cyanotic after birth. They may not. It depends on how the baby grows and how those vessels grow over time. But the point being is that tetralogy may be a ductal dependent lesion if there's atresia or severe stenosis of this pulmonary valve, or it may not be. But with that 4-chamber view alone, you may potentially miss this diagnosis. So here's an example of some aortic arch abnormalities. And I think the most important part of these examples is that, again, you're in a very different plane. So here what you're seeing is your aortic arch. And here we had two side-by-side images, one of a normal aortic arch and one with a significant narrowing, suggestive of coarctation. The major point I'd like you to take away from this is that we don't see the forward chamber view at all in this plane because we're looking at the heart from a completely different perspective. So if you're only looking at that forward chamber view, you can potentially miss a coarctation, and that could potentially be a ductal dependent lesion if it's severe enough. This is actually not a fetal image, it's an MRI image, but I think it illustrates one very important point. We're looking at the aortic arch here on the left-hand side, and then the ductal arch. So here's the right ventricular outflow tract, pulmonary valve, main pulmonary artery, and then the ductus arteriosus connecting to the descending aorta. Whereas here, we have the aortic valve with the ascending aorta, transverse aorta, and then descending. So on a very superficial look, those two arches look pretty similar, and they're very close to one another. So you have to very subtly sweep from one direction to the other, otherwise you could potentially miss a narrowing in one of those arches. So very, very subtle motions are needed to really differentiate the two and to get a good look at those two. And again, this doesn't show you a four-chamber view, so that four-chamber view alone is not very comprehensive. And we talked a little bit about the three-vessel view, and I hope this example illustrates that. So if you're looking at the patient, here's their heart on the right side, on this side, and here's the left-hand side, and you're cutting through the level of these three vessels. You have the main pulmonary artery, the aorta, and then the superior vena cava. So imagine if you were at that level and looking down at the heart. This is actually reversed. Just kind of mentally flip it. Here is the main pulmonary artery. Here is the aorta, and they come together at the ductal insertion of the aorta. And here is the superior vena cava. And here's just a schematic illustration. Your main pulmonary artery with your ductal arch, your aorta with the aortic arch, and then your superior vena cava. So those views help us look at the outflow tracts, and again provide us very, very critical additional information. So now we transition into the postnatal screening, what that means and the purpose and things like that. So we now have universal congenital heart screening, and this actually becomes most important in instances where we don't have prior fetal concern. So there's a good percentage of patients that we see who now have a prenatal diagnosis, and again, our major goal is to get those parents and those families to deliver at the safest possible place. But there's some instances where at the end it's obviously survey looks normal. Those patients can slip through the cracks, and so we still need the universal CHD screen to help catch either those mothers who were lost to follow-up, had improper prenatal care, they never showed up at their visits, and things of that nature, or if there were just some technical limitations to their OB scanning. So we talk about the role of postnatal echocardiograms. And so there have been studies, meta-analyses of the universal CHD screen, and it turns out that the pooled sensitivity and specificity of pure pulse ox screening is actually very similar to antenatal, where the pooled numbers are about 69% and 99% respectively. So I think the primary objective of the universal CHD screen is not only to detect congenital heart disease, but really to detect the critical congenital lesions. If you have a patient who has an ASD, VSD, those patients are not necessarily going to be symptomatic after birth, and they can potentially be followed just as an outpatient. We're really more interested in the patients that can potentially be a hypoplastic left heart syndrome or a critical coarctation that we need to act very, very quickly. Because remember, the definition of critical means that you have to act within the first month of life. So some of the caveats to the CHD screening, and I'll go through the algorithm shortly, is that some of these babies may present late, and a lot of that is dependent upon, if you think about it, it makes sense because these are babies who are ductal dependent. So it may not be until that ductus closes or starts to close that they will actually manifest with symptoms. So some of the neonates with critical CHD are asymptomatic during their birth hospitalization, but develop signs or symptoms after discharge. It can be up to 2 weeks of age, and it depends on their underlying lesion, because with certain critical CHD, that ductus may take a while to start to become smaller. Infants with non-cyanotic heart defects, like a pink tetralogy of flow, where they don't have much in the way of right ventricular outflow obstruction, and some left heart obstructive lesions will not be identified by pulse-ox screening. And these are the ones that we really want to make sure that we catch. So some of the signs and symptoms of critical CHD can be very, very subtle, particularly until that PDA closes. So prior to the initiation of the routine pulse-ox screening, the most commonly missed diagnoses during hospitalization are listed here. So from the right heart, so pulmonary stenosis, tetralogy of below, because again, depending on the degree of narrowing, they may or may not be cyanotic. Left heart lesions, like hypoplastic left heart syndrome, coarctation of the aorta, interrupted aortic arch, aortic stenosis. Again, a lot of this depends on the degree of obstruction to the left heart. So hypoplastic left heart syndrome, there are actually several different variations and different extremes. You can have a baby with complete atresia of the mitral and aortic valves, or you can have a baby with just very mild stenosis of both of those valves. And then obviously there are different variations in between. So depending on the severity of their anatomy and physiology, that will determine the timing of their presentation. So pulse oximeter screening is going to target those patients that we can potentially otherwise miss. So how do we evaluate, or how do we approach these patients? So if they're symptomatic, this is essentially the algorithm that we go through. So obviously physical examination, pulse ox, plus or minus chest radiograph, EKG, hyperoxia test. It's actually very, very useful. And also echocardiography. That's really going to give you the most important information. If they're otherwise asymptomatic patients, so again, looking for subtle signs or symptoms that can clue you in to potential congenital heart disease. So are there abnormalities of the baby's heart rate? Their precordial activity, do you feel a thrill like when you're palpating the baby's chest, or abnormal heart sounds, or loud heart sounds, so something to suggest elevated or abnormally elevated pulmonary pressures. Murmurs, of course, especially if they sound pathologic. Diminished or absent pulses, blood pressure differentials, and we'll go through that in a little more details. And again, if they have extracardiac anomalies, think about the possibility, just keep CHD on your differential diagnosis. So the aims of universal screening is screening for critical congenital heart disease in all newborns after 24 hours of life, or as late as possible. Because again, we want to give that ductus enough time to close on its own to see if the baby will manifest him or herself. So again, the screening does not identify all critical CHD. And if they have a positive screening result, then they definitely need a cardiac evaluation to figure out at least rule out a cardiac cause of the hypoxemia. So this is the algorithm that is proposed for CHD screening. So on the right-hand side, so if the baby's saturations on the right hand or foot is equal to or greater than 95%, and if there's no difference between the upper and lower extremity saturations, then the baby passes. So this is pretty easy. Baby passes, and everything, for the most part, should be fine. Then on the other extreme, if the baby has saturations less than 90 in the right hand or foot, then the baby fails and needs further evaluation. This is the most challenging area where there's going to be perhaps subtle changes that may clue you into CHD. So sometimes they may hover just around 90% or between 90 and 95 in either the right hand or the right foot. they may have a subtle difference between the upper and lower extremity saturations. If that were to be found, then the recommendations are this is considered to be indeterminate at that time, so repeat it in an hour. And then if you get the same result, repeat in an hour, and if it's still, you're still in that same scenario, that is considered to be positive, and you want to proceed with screening with echocardiogram. So in the interest of time, I'm not going to go through those. I think we've already got through some of those principles. Here's just basic anatomy of the heart. And just haven't shown you the anatomy of the PDA, but the PDA connects the pulmonary artery to the aorta. And so keeping this picture in mind will help understand some of the examples that we'll go through. So what are the potential screening outcomes for the CHD screen? So if you have cyanosis of both the upper and the lower extremities with no differential, and for example, if you have both in your right arm and your right leg, you have 88% and 86%. So that's considered to be cyanotic, but you have no difference in the right arm or the right leg. That gives us a very broad differential diagnosis, because that tells us that there's complete mixing or potential for complete mixing within the heart. So all the extremities are seeing the same saturation. This becomes more of the challenge. What if we have differential cyanosis? And what does that mean? So we have cyanosis, and there's more than a 3% difference between the upper extremity and the lower extremity. So in this example, we don't have cyanosis in the arm, but there is a very significant difference between the arm and the leg, more than a 3% difference. Or what if both were cyanotic, and there's a significant difference between the arm and leg? So what could be potentially happening? So what's happening there is that there's some right to left shunt across the ductus that's resulting in taking that deoxygenated blood from the right side of the heart and sending that over to the left side to the systemic circulation. So you can actually have normal intracardiac anatomy, but this could be a premature baby with pulmonary hypertension with a large PDA. So with that pulmonary hypertension, the baby can have a structurally normal heart, but because of that increased resistance, so I'll go back a couple of slides, if there is increased resistance here, that's going to promote right to left shunting here, because blood will follow the path of least resistance. So that's a scenario where you can have a normal upper extremity saturation, but diminished lower extremity saturation, because the lower part of the body is getting the deoxygenated blood because of the elevated pressures. Meanwhile, everything else inside of here is entirely anatomically normal. But also, you can have congenital heart disease, particularly in left heart obstruction. So you can have critical coarctation or interrupted aortic arch present in a similar fashion. So in those instances, there's a high resistance from the left heart obstruction that promotes that right to left shunt. And then this is beyond the scope of our discussion today, but if you have reverse differential cyanosis, where essentially you have the right leg or the lower extremity has a higher saturation than the upper extremity. So that can be seen with transposition of the great arteries with coarctation or pulmonary hypertension with coarctation. Again, beyond the scope of what we're discussing today. So this is our target, to look for ductal dependent lesions. So how do we approach this postnatally? And this is before we end up getting the echocardiogram to make the diagnosis. So ductal dependent lesions will have an acute presentation, typically upon closure of the ductus. So if they're ductal dependent for systemic blood flow, this could be a baby that presents in shock, and that makes sense because their systemic circulation is compromised. They're not getting enough blood flow to their extremities, and that's a true definition of shock, where you have insufficient blood flow to allow for that specific metabolic demand. You can also have, like we talked about before, differential cyanosis for the normal upper extremity saturation. If you're ductal dependent for pulmonary blood flow, you're more likely to see either respiratory distress, cyanosis, or hypoxemia, or some combination thereof. So if you're ductal dependent for systemic blood flow, you're thinking more shock, acidosis, reticular diffusion, whereas if you're ductal dependent for pulmonary blood flow, it's more respiratory compromise. Then these are some of the, again, some of the examples of left heart obstruction, and I have some examples to illustrate that. So here's a patient with hypoplastic left heart syndrome, and this is the severe extreme where you have atresia of the mitral valve, so that never formed, and either atresia or near atresia of the aortic valve. So the only way this baby's body can get any blood flow is through the ductus arteriosus, and that baby is going to be quite cyanotic and have all that blue blood going out to the systemic circulation. Critical coarctation. So illustrating the example that we talked about before, where these babies may have, if you're checking the saturation in the right arm, it may be completely normal because they have normal pulmonary venous return. They get a nice complement of oxygen-rich blood coming back to the left heart, going into the left ventricle, and then out to the right arm. But if they have a critical coarctation, meaning they're dependent on this ductus to overcome this obstruction, their lower extremity sats might be very, very low. Intracranial aortic arch is just an extreme version where you have some disconnection between the ascending aorta and the descending, and they're actually different classifications and different types depending on where that interruption occurs. But the similar concept where the lower extremities have compromised oxygen saturation because of the ductal, the right to left ductal shunt. Critical aortic stenosis. So this all depends on the degree of narrowing across the aortic valve. So again, depending on that, the baby is going to be dependent on the ductus arteriosus to provide blood flow both to the descending aorta, but you can have also retrograde flow. And you need to have retrograde flow because the coronary arteries come right off distally, just right after the aortic valve, and they also need a blood supply. So if they're not getting adequate blood flow in this direction, they need some retrograde flow to actually perfuse the myocardium. And then I'll show some examples of ductal dependent lesions for pulmonary blood flow. So essentially thinking of right heart obstruction. So tricuspid atresia, so we saw this example before. Here we have complete atresia of the tricuspid valve. It did not develop at all. So we have what's considered an obligatory shunt at the atrial level. There's no other egress for this blood to go. There has to be some atrial level communication. But here we're taking all this blue blood and it's shunted directly out into the baby's body. So there's no way for blood flow to get to the lungs except if you have ductus arteriosus, but also depending on a ventricular septal defect in this case. Not all babies will have a VSD as well. And it also depends on the size of the VSD as well. Pulmonary atresia, very, very similar example. Here we have complete atresia or abnormal or lack of development of the pulmonary valve. So the only way to get blood flow to the lungs is through ductus arteriosus. So blood has to shunt across either at the atrial level or the ventricular level. Not all babies will have a VSD with pulmonary atresia, but you have to have some shunting right to left out to the systemic circulation, or that systemic circulation just provides the pulmonary blood flow on its own, but you need the ductus in order to provide that. Tetralogy flow, so this would be ductal dependent if you had pulmonary atresia, but otherwise it may not be ductal dependent. And then that just brings me to some summary points. So the use of the 4-chamber view alone on obstetric ultrasound or fetal echo has very significant limitations and very low sensitivity. So once we incorporate the outflow tracts and the aortic arch or the arch views, both ductal and aortic, that can significantly enhance your sensitivity and really help us pick up those critical lesions. There are also limitations of fetal echo that we talked about. It could be secondary to just the gestational age and the heart size, limited acoustic windows, maternal factors, or the physiologic considerations that we've talked about before. And then universal screening for CHD allows for early recognition and intervention for critical lesions. But there are caveats to the universal screen, where there is a small subset of patients that can be missed. So having that clinical suspicion is very important. And that was actually my last point. So that's part of our Central Washington state. That's just Tri-City. We also have Dr. Schmer and Dr. Barnes here at Children's Village. So that concludes my talk, and I'm more than happy to answer any questions you might have.